from San Francisco. It's my great pleasure to present at this webinar, Aced in the World. I'm going to be presenting a case of SMA syndrome. Here are my disclosures, and I will be speaking on the Axios lumen-opposing metal stent and delivery system. This is an 80-year-old male with nausea, vomiting, severe abdominal pain, weight loss, significant weight loss over the past 6 months. And he's admitted to an outside hospital in very frail condition. And he has a CT scan done, and you see that here on the right side. You see the stomach, the body here is markedly distended. This is the antrum, also distended, and the duodenum is distended, and here you see the SMA. And the SMA appears to be compressing the duodenum. We don't see any downstream small bowel dilatation. So he has an upper endoscopy, and here in the transverse duodenum, you can see extrinsic compression of the lumen here, and we are unable to traverse this extrinsic compression. So he has an endoscopic ultrasound exam, and this confirms SMA syndrome. It shows here the superior mesenteric artery that is compressing extrinsically on the duodenum. The duodenum itself is completely normal. So a fully covered SEMS was placed across the compressed area, and it was sutured in place. And the patient's obstructive symptoms fully resolved. However, 2 weeks later, he's readmitted with nausea and vomiting. He's starting to lose weight again. His EGD now shows that the stent has proximally migrated into the stomach, despite the sutures still being intact. So we remove the stent. And this video here will show this. This is the suture cutters that we're using to cut the sutures. And then with the rat tooth forceps, we're grabbing the proximal end of the stent and we're dragging it out of the esophagus, out of the patient. So we discussed an EUS-guided LAMS gastroenterostomy for this patient who's not a surgical candidate, and he's agreeable to that, and we reported on this back in 2012, first in porcine studies using the lumen-opposing metal stent, the axial stent in this case, and you can see here the distal and proximal anchors creating that anastomosis, the efferent and afferent limbs, and the conduit that we've created between the stomach and the jejunum. And the electrocautery enhanced delivery system allows us to place the LAMS as a one-step, one-device procedure. So there's no over-the-guide wire exchanges of devices. So it minimizes the risk of displacement of our target organ from the stomach wall, in this case, the jejunum or the distal duodenum. This video shows EUS-guided GE using a 15mm by 10mm LAMS. This is the area of the compression compression, and we are negotiating this stenosis with a guide wire first using an ERCP catheter. You see the guide wire now being advanced distally into the downstream small bowel. And then we exchange the ERCP catheter for a injection catheter. It's a 7 French injection catheter, remove the guide wire, and then we can infuse water into the small bowel, and we can distend the downstream small bowel for better visualization. And now we can perform our gastroenterostomy. This is the electrocautery enhanced delivery system, enabling puncture of the downstream small bowel, and then we can immediately place a guide wire into the downstream small bowel, and we can deploy our distal flange. You can see that very nicely here. It's very echogenic. We snug it up against the wall of the small bowel, and then we place our proximal or deploy our proximal flange, and we immediately see fluid draining out of the small bowel. So we have confirmation that we've created the anastomosis. We can dilate the lumen of the LAMS, and then we can switch out for a gastroscope, and we can pass through the LAMS using it as a port to the small bowel, and we can intubate the efferent and afferent limbs. And here the the X-ray nicely shows the LAMS in place. 3 months post-EUS gastroenterostomy, he comes for a routine follow-up. He's tolerating a regular diet well. He's gaining weight. He's doing very well. And our EGD shows a patent LAMS. And we are able to enter through this with our gastroscope without any resistance or difficulty. We're intubating the afferent limb now, and you can actually see the pulsations of the SMA on the left side. And we encounter the stenosis again, which we cannot traverse with the diagnostic gastroscope, just as we could not traverse previously from above. So the stenosis is persistent despite the patient having gained weight. So we decide at this point to upsize the LAMS to the 20 millimeter diameter, and this video shows the removal of the 15 millimeter LAMS using a rat tooth forceps. We can just pull that right out with steady traction. So it pops out of the fistula tract, which is now mature, of course, and we're able to traverse that fistula tract with our scope. And now we are placing the 20 millimeter LAMS. You see the distal flange deployed under endoscopic guidance. So this is not necessary to use EUS for this. Now the proximal flange. So here, once again, we have a nice X-ray view of continuity between the stomach and the downstream small bowel. So we left the 20 millimeter LAMS in place for nearly a year, and the patient did marvelously during this time. His weight's now stable. He's asymptomatic. And so we opted then to remove the 20 millimeter LAMS, hoping that he now has a sufficiently mature tract and won't need the LAMS long term. However, 3 months after removing the LAMS, he presents with recurrent obstructive symptoms. And here on the video, you see that the gastroenterostomy has closed down. So fortunately, we're able to cannulate the opening with an ERCP catheter. We place a guide wire into the downstream small bowel, and we've decided now to replace the 20 millimeter LAMS, but we're going to leave that in long term, and our decision or our recommendation for the patient was that he return yearly for a exchange of his 20 millimeter LAMS. So here you see the new 20 millimeter LAMS being deployed. So in summary, EUS guided GE can provide effective symptomatic relief of SMA syndrome. However, rapid closure of the fistula tract can occur after LAMS removal, even after 1 year of placement. A permanent LAMS may therefore be required, and we should reserve EUS-guided gastroenterostomy for patients with SMA syndrome who are non-surgical candidates. These patients need to return yearly for LAMS exchange. Thank you.